Okay, let's dive right into an explainer that basically plays out like a high-stakes clinical detective case. Today, we're zeroing in on acute pancreatitis, that sudden, super severe inflammation of the pancreas. We're going to break down the clues, round up the usual suspects, and unpack the life-saving treatments for this absolutely fascinating and, let's be honest, potentially deadly medical puzzle. Let's get into it.
Picture this. A patient rushes into the ER. They're dealing with this intense, sudden epigastric pain. But this isn't just your run-of-the-mill stomach ache. The defining feature here? The pain shoots straight through to their back. Patients literally describe it as feeling like a spear stabbed right into their abdomen. It's sudden, it's unrelenting, and it absolutely demands our immediate attention.
And this brings us to the ultimate medical puzzle, right? When you're faced with a patient suffering from acute epigastric pain, distinct tenderness, nausea, and severe vomiting, what exactly is our most likely culprit? As clinical detectives, we have to sift through these symptoms to pinpoint exactly which organ is failing.
Part 1. The Spear of Pancreatitis.
You know, we can actually narrow down our list of suspects right off the bat just by tracing the path of the pain. Think about biliary colic or cholecystitis, issues involving the gallbladder. That pain wraps around the side to the back. But acute pancreatitis, it's a totally different beast. Its pain radiates straight through the body to the back, matching that spear-like description perfectly. It's a huge clue.
Let's examine the crime scene. The mid-epigastric region, so right beneath the xiphoid process and above the umbilicus. This right here is ground zero for acute pancreatitis. While issues like appendicitis tend to hide down in the lower right and splenic ruptures up in the upper left, pancreatitis strikes right in the dead center.
And it gets worse. As the internal trauma progresses, the intense inflammation can literally cause surrounding blood vessels to leak. This leads to retroperitoneal hemorrhage, blood collecting behind the abdominal cavity. When this happens, it gives us this massive, glaring physical clue on the outside of the body called the Gray-Turner sign. You'll see it as severe bruising right along the patient's flanks.
Moving on to Part 2. The suspects behind the inflammation.
There's a fantastic mnemonic medical students use to remember what causes this condition. I get smashed. Now, gallstones are a #1 most common offender, followed really closely by alcoholism. But just look at the rest of this list. We're talking everything from physical trauma and hypertriglyceridemia to medications like sulfa drugs and, get this, even scorpion stings. No way, right? But it's true. It's a huge array of triggers all causing the exact same acute inflammation.
Surprisingly enough, sometimes an investigative medical tool turns out to be the suspect itself. Endoscopic retrograde cholangiopancreography, or ERCP, is a procedure we use to diagnose and treat duct issues, but it can actually induce pancreatitis. The good news, though, we can totally prevent this procedure-induced trauma just by administering rectal NSAIDs, specifically indomethacin, right before the procedure. A simple fix for a huge problem.
Section 3. Solving the diagnostic puzzle.
This sequence is essentially our medical forensics playbook. We start broad, then get specific. The absolute best initial tests are checking the blood for elevated pancreatic enzymes, specifically amylase and lipase. Once those are elevated, we escalate to the most specific test, a CT scan or MRI with contrast. This lets us visually assess the damage and hunt for complications like pseudocysts. Finally, if the imaging reveals extensive dead tissue, meaning greater than 30% necrosis, we jump to a needle biopsy to test for severe infection.
But, you know, every detective hits a snag, and we've got to watch out for false alibis. Remember earlier when we listed hypertriglyceridemia as a cause? Well, here's the kicker. Incredibly high levels of triglycerides in the blood can actually falsely decrease your amylase lab readings. We have to be super careful not to let a normal amylase level trick us if the patient's blood is just thick with lipids.
Part 4. The True Mark of Severity.
Okay, it's time to bust a major myth. If you're standing there looking at a patient's chart, which factor actually points to the worst possible outcome? Is it the crazy intensity of that spear-like pain? Or maybe it's those sky-high levels of amylase or lipase? Let's look at what actually predicts the worst prognosis. The shocking answer? It's low calcium. And the biological science behind why is just fascinating. See, severe pancreatic damage decreases the release of lipase into the gut, which leads to fat malabsorption.
Inside the bowel, the body's calcium starts binding with this unabsorbed fat in a chemical process called saponification. It's literally a biological soap-making process happening inside the gut. This yanks calcium right out of the body's system, leading to dangerously low blood calcium levels.
So yeah, the pain level and those super high enzyme counts, they're completely subjective red herrings. A patient could be screaming in agony with astronomical amylase levels and end up recovering just fine, while someone else might have lower enzymes but be in critical, life-threatening danger. True disease severity simply does not correlate with pain or enzymes. It correlates strongly with the degree of tissue necrosis seen on that CT scan and biological markers like that low calcium we just talked about.
Finally, Part 5, Life-Saving Treatments.
Once we've got our diagnosis, our immediate intervention is all about shutting the entire system down to let it heal. We make the patient NPO, meaning absolutely nothing by mouth. This completely rests the pancreas by halting digestion. At the exact same time, we're aggressively hydrating the patient with high-volume IV fluids, providing strong analgesia to manage that brutal pain, and pushing proton pump inhibitors to decrease any acid stimulation from entering the duodenum. As we monitor them, our imaging completely dictates our next move. If that CT or MRI reveals significant tissue death, specifically greater than 30% necrosis, the risk of a fatal infection absolutely skyrockets. Right at this threshold, we deploy targeted, heavy-hitting antibiotics like imipenem or meropenem, which have been proven to significantly decrease mortality. And as a true last resort, if that dead necrotic tissue unfortunately does become infected, a status we confirm using that needle biopsy we mentioned earlier, well, medical management just isn't enough anymore. Surgical removal with physical debridement of the infected tissue is absolutely critical here to prevent acute respiratory distress syndrome, or ARDS, and ultimately save the patient's life.
And with that, this case is closed. We've tracked acute pancreatitis from its brutal spear-like symptom right through its wild array of triggers, navigated past the diagnostic pitfalls of false alibis and red herrings, and arrived at targeted, life-saving therapies. But it definitely leaves us wondering, knowing just how stealthy and complex the human body can be, what other fascinating clinical puzzles are waiting for us to uncover